Welcome. My name is Steve Eck, and I'll be introducing today's Modern Healthcare Custom webinar, Value-Based Care Innovation, How Providers, Payers, and Tech Can Collaborate to Drive Better Clinical and Financial Outcomes. As demand for value-based healthcare models grow, the most innovative healthcare companies are using analytics to develop standardized episodes of care at scale to optimize performance. Today's webinar features an expert panel of industry leaders, physicians, and technologists exploring how new technology and collaboration are creating powerful VBC models. A couple housekeeping notes before we get started. We want this webinar to be an interactive experience for our audience. You are encouraged to ask questions using the questions pane in your GoToWebinar attendee panel. Our speakers will try to address as many of your questions as they have time for. Should you need any assistance during the webinar, please don't hesitate to contact us via the questions pane in your attendee panel. Before we get started, we'd like to thank our sponsor, Change Healthcare. Change Healthcare is a leading independent healthcare technology company focused on insights, innovation, and accelerating the transformation of the U.S. healthcare system through the power of the Change Healthcare platform. I'm thrilled to introduce Dr. Summer Paul Kalan, Vice President, Value-Based Care from Change Healthcare, who will be introducing our panelist. Summer serves as an advocate for the advancement of value-based care, engaging stakeholders across the healthcare continuum to promote adoption of advanced healthcare delivery models. With Change Healthcare's vital role in enabling key elements of value-based care, Summer works with the entire Change Healthcare team to identify ongoing opportunities to change the status quo in healthcare. He is also a practicing physician and infectious disease specialist. Summer, the floor is yours.
Thanks, Steve, and good afternoon, everyone. We appreciate you taking the time to join us today and share our thoughts with you, and we very much look forward to the Q&A at the end as well. So as we get together today, many of you may be really steeped in the idea of value-based care. Others of you may be just very early in your journey. For us at Change Healthcare, we've been in this space for a long time, and as we've been in the space really helping create data and technology applications and analytics that support the transition from fee-for-service to value, I think one thing that's become obvious learning over the years requires collaboration. So it's not only about data, it's not only about analytics, certainly not only about providers or only about payers. It's everyone working together and collaborating so that we can use technology, we can use data and insights to really drive collaborative decision-making, collaborative operations, and collaborative success in delivering value. So I'm joined by a panel today who really have an outstanding collective background in working together amongst each other and as well as with other partners across the industry to help really define and create value and then deliver value. And it done so in a way where we continue to evolve, learning from what we've done before and today, and informing how we continue to innovate in the future. So I'm joined today on the panel by Siva Tunga, who's General Manager at Nuna Health, which is an innovative health technology company based out of California, as well as Mignon Norman, who's a contract manager with Blue Cross Blue Shield of North Carolina. Mignon and her team at Blue Cross Blue Shield in North Carolina have really been leaders in this space. BCBS North Carolina has been one of the innovators for years and continues to really be on the leading edge as a payer. In addition, I'm joined by Dr. Jack Feltz. Jack is the Chief Medical Executive Officer at Unified Women's Healthcare and also the President of the U.S. Women's Health Alliance. Jack's background in OBGYN and his organization's commitment to value delivery really has been manifested in a journey from very early on, really taking the effort to understand what it means to deliver value and constantly working to adapt, change, and continue to be able to deliver value even as those concepts of value change and the tools available to us continue to change. And leading our session today is going to be our moderator, Lily Brillstein, who's the Chief Executive Officer at B Collaborative Consulting. Lily has a deep background in value-based care, working with payers and providers, and in particular helping bridge with providers the understanding of really what it means to be involved in value-based care, how to be successful in a way that benefits everyone in the ecosystem, the members and patients in particular who really benefit from these programs. So Lily, I'll hand it over to you as our moderator to take us into the panel.
Thank you so much, Summer, and welcome to everybody. Thanks for joining us, and thanks for for asking me to moderate, one of my favorite things to do. And I absolutely love a conversation about collaboration. One of my mantras is teamwork makes the dream work, and I think that is nowhere truer than in building models that really focus on patient care, patient outcomes. So I'll just start us off by saying I think hopefully we're coming out of the public health emergency and the pandemic, and there have been so many learnings, I think, during that time that relate to this movement from fee-for-service to fee-for-value, not the least of which is we have figured out really well how to create collaboration like this virtually so that we don't have to only collaborate with those who are physically closest to us, but we can collaborate with those who are doing the very best work. And I think we've learned a lot about building meaningful collaboration. And one of the things that I often kind of always say when I'm talking with groups about creating strategy for engaging value-based care models is we need to build models that are clinically meaningful, but that also can actually be administered. And that last part is not always considered by all of the various groups. And so I am absolutely delighted that we have a payer and a provider and a tech guy and a doctor data analyst guy so that we can get a variety of perspectives today. In my own work, I have used the Prometheus tool across the country as a basis for building a lot of these episodes of care models. And I think as I listen to what's happening with CMS and the MedPAC recommendations and also to commercial payers, there's a really big push these days to sort of create models that sort of harmonize with one another so that we get to that sort of all-elusive medical neighborhood. And I think one of the key concepts that we keep hearing is how do we make it more simple? How do we actually build models that have some synchronicity, between specialty and primary care and integrated delivery. So with that saying, I have to say that I always think one of the keys to success, I have experienced this, is collaboration. And I'm going to start with one of the people that I collaborated with very, very early on in this movement, which is Dr. Jack Felt, when at the time I was working for Horizon, the Blue Cross Blue Shield plan in New Jersey. And we had started building really what I think was one of the very first maternity models in the country. And Jack, I would love it. I'm sure that everybody would love to hear from your perspective. What were those early experiences like in terms of how did we work together, you and other payers, and how did you build these models? And then also, I think it's really interesting the evolution of one particular episode, which I think in the maternity space was particularly interesting, how we were able to use the algorithms and the models to kind of get to a really robust model for delivery. So will you start us off, please?
Sure. Thanks, Lily. I appreciate the opportunity. So before I answer that directly, I just want to back up 1 second. When you talk about evolution, value-based care is nothing new. I believe I started my journey in value-based care 40 years ago when I finished medical school and took the oath called the Hippocratic Oath. And quite honestly, value-based care goes back all the way to Hippocrates, the father of modern medicine 2,500 years ago, when he said, do no harm and comfort always. So value-based care is nothing new. What is new is that now we've defined it and we call it value-based care. We now have tools that we can use to actually improve. And that is somewhat new. One of those tools, as you just discussed, is the episodes of care. So value-based care is the care we give as providers, and the tools are everything else, such as alternative payment models, episodes of care, actionable data analytics, and such. And the journey I started on with Lily, which was an incredible journey going on almost 10 years, was looking at how we can give better care to women, and specifically in our episode of care to pregnant women. And because we all know that pregnancy is a very, very important time in a woman's life. A woman's very vulnerable to issues, but yet it's the most normal condition in the world. And so working with Lily and her team at Horizon Blue Cross and Blue Shield at the time, we looked at how do we give better care to women through one of the tools, which was our maternity episodic care. We began that by collaborating, because the same as there's no I in team, there's no I in value-based care. I don't think so anyway. I wasn't that good at grammar and spelling in high school. And so basically, it's really a team effort. And we created a team between the providers at Lifeline Medical Associates, my group, and Horizon Blue Cross and Blue Shield to really think about how we can evolve into better care for women. We started with normal risk pregnancies. We evolved it into a higher risk pregnancy model. And then we also wanted to include the baby, because we know that one of the biggest problems in pregnancy is babies that are born premature. And that's not only bad for the baby, bad for the parents, bad for society, but it also is very expensive. And it creates a burden on families and a burden on the system to be able to use our resources for better things. So we collaborated along that whole continuum to really give better care to our patients by measuring every single thing we did, so that we were able to show our physicians at the point of care what the opportunities were and how they can improve. Because there's no shortage of good doctors in this country. I don't care what anybody says. There's no shortage of good hospitals. There's a shortage in the process in which we deliver care, the consistency and the fragmentation where everything is siloed. And so with maternity episodes of care, working with health plans, providers, our hospital systems, we're able to bring all of those siloed groups together into one collaborative, and the patient really benefits by that. And we've shown great success at Lifeline, and now at our organization, Unified Women's Healthcare, where we take care of over 3 million women at the U.S. Women's Health Line, where we take care of over 10 million women, where we're really starting to see that paradigm shift where doctors think of the care they give, not as only what incremental care they give to that one patient, but all of the care downstream that they can take some level of responsibility. So it's really the total care for the woman, not just some tiny part. And in collaboration with other stakeholders, I think we're making a huge impact. I think doctors are becoming happier with the care that they're delivering. And we know healthy, happy doctors give patients better, more affordable care. So that's been our journey with Lily, and then with other health plans across the country. And we're really excited to work with everyone. We're working with Mignon at Blue Cross and Blue Shield in North Carolina, with some of our North Carolina groups at Unified, and really looking for a future that changes healthcare the way women in our specialty need it, and all of our people in America need it.
Thank you so much, Jack. So Mignon, I'm going to maybe shift to the payer side. And I know so often, what I said earlier is the goal really is to build models that are clinically meaningful that can also be administered. And very often, the only one thinking about how the program can be administered is the health plan. And the health plan often gets a very bad rap because people think they say no, because they like to say no, but in fact, they sometimes say no because they simply can't administer what's being proposed. So with that as a backdrop, I'd love to understand, from your perspective, what are the challenges that you have experienced or do experience in terms of engaging providers and launching these kinds of models? And before I finish the question, I'm going to ask you too, North Carolina is a little bit unique in terms of it had launched early on some prospective models and is now also launching some retrospective. So it'd be really interesting, I think, to hear a bit of the journey that you've been on as it relates to how to engage and how to build these models that have clinical meaning and actually can be administered.
Thank you, Lily. I'm happy to talk a little bit about that. We did start the value-based bundle payment venture, or however you want to look at it, several years back. And we started in the orthopedic space, and we were probably some of the first prospective bundles that were, I know, in North Carolina. So yeah, we started out with knee replacements and hip replacements, and we have since expanded some of those orthopedic procedures into like knee arthroscopies. We're expanding there, and some spine episodes as well, and some shoulder replacements. Orthopedic being the focus for such a long time, we really wanted to, as a company, look at how can we expand our bundles in a way that could bring in other specialties. Orthopedic, like I said, that had been our primary focus. There's a lot of spend there, but there's so many opportunities that that are out there, and we have so many standardized methodologies that we can utilize, like the Prometheus methodology, where we can pull in other specialties. So we're now starting to look at and we actually have expanded to, thanks with our partnership with Unified, a maternity retrospective model. And we will also be expanding into the radiation oncology space, as well as gallbladder. We're looking at several of those episodes, and maybe even some colon resections as well, and colonoscopies and endoscopies. So we're really trying to bring in some other specialties into the mix, because value-based care is the only way we are going to be able to work with our providers and help rein in healthcare costs. So we see that, we recognize that, and the only way to do that is to expand and to grow our programs. So that's become an increased focus on our company, for our company, and so I'm happy to lead that. Some of the challenges that we have had is really internally with our claims processing systems, to start with our programs, or with our program originally, everything was a manual process. Like, we did not have a lot of automation in place. So of course, with manual process, you have errors. I mean, that happens. And there was some frustration with that, initially, but we recognize the importance of investing in software and programs that could, and partnering with vendors where we could streamline and get everything automated, where, we have less of those errors, and we can report to providers and show them what episodes they have in flight, and, before it actually closes out, and things like that. So we're trying to work with our providers on giving them the data that they need throughout the episode, which is something, that we haven't been able to do as much, as early on in the inception of when we started this. So we've really invested in the system area where everything can be automated and we can expand like we want to expand. And again, partnering with great providers, with great vendors, having our systems where they need to be. And that is one of the issues that we have run into as far as our claims processing system. We're currently working off of 2 systems, and one does more than the other. So we're kind of migrating off of one. And part of that process has, we have to, it puts more administrative processes on the providers up front for our prospective bundled partners. And that's some of the issues that, or I say hiccups that we've had in getting, our providers on board, because we require like a separate MPI for setting up a bundle, entity and things like that. So there has been some issues with that, but as we move into getting away from our old legacy system onto a new platform, everything should be automated. So bringing everybody on board at a larger scale will be much easier. And our retrospective models, which we are really expanding those at this time in the maternity space and the radiation oncology space, there's no administrative issues. We accept claims as they come to us. There's no initial setup providers, and then we do everything at the back end. So that has really helped in making things easier for our providers up front. So just looking at all of that and figuring out what works and learning over the years and as long as we're nimble and can evolve and can meet our provider needs, we're going to keep pushing and keep doing what has to be done. to share data, to give them what they need so we can all be successful. Ultimately, you know, the way we look at it as a health plan is we want our providers to be successful. And our shared savings arrangements, we want them to have shared savings. I mean, we want them to recognize the value and the opportunities there and capitalize on it. You know, if they're winning, we're winning. And that's the way, and our members are winning. So, you know, that's what we look at as a health plan. And it's just so important that everybody partner in such a way that we can achieve the same goal.
Thank you so much. You know, it's so interesting. We very rarely, if ever, hear the word nimble used to speak about a payer. And so, Siva, I'm going to turn it to you because, you know, one of the things I think that has really happened is there's been a lot of swift movement in terms of new digital tools, in terms of analytics and capabilities that really come in underneath to support the plans and the providers. It supports the plan's ability to be nimble, actually, and provide the information that the providers need to really create success. So if you could share with us your perspective and what's new and what's coming, and just sort of the various tools that are available that support these sort of new and innovative ideas, that would be terrific.
Yes, thanks. So as we know, the patients are moving through the healthcare system where we are struggling to find out the complete picture of the patients. And that's where what we call the transparency, interoperability of data and the platforms which can bring both claims, clinical data, as well as socioeconomic data together in order to support the value-based care programs. The tools are kind of evolving and learning, and with the new pandemic, COVID, we learned new data streams as well as data sets which are available to understand the population and the utilization and the post-pandemic's impacts. So what it is coming to from a technology standpoint is most of the tools and the data availability is becoming more and more. As we know, CMS is also pushing data transparency and public use of data available. So most of our plans or the vendors from a technology standpoint have leveraged platforms like the all-payer claims databases, which are available across various states, which are more commonly provided with a lot of membership data, which is used for identifying the actual needs from a care perspective, looking at the variations of care across the population, and creating the right value-based care models based on the aspects of social determinants of health, such as the level of education, income, the accessibility of the services. So these have driven to kind of design new value-based care programs, as well as within the episodic of care, identify those early ahead of time so that the providers can determine and inform them earlier from a standardization of care, more from reducing the cost as well as reducing their visits to urgent cares or hospitalizations. So one of the things which is more predominantly happening with the CMS is data at the point of care, where CMS is willing to give access to practices who are willing to participate in an connectivity to populate the Medicare fee-for-schedule data or the fee-for-service claims data for Medicare population. So that's a very powerful tool if you are managing an episodic care or identifying the population or members whom the claims data information is available for the providers to make better decisions at the right time point of care. The second one, if you look at it, there are commercial data sets which are available, which are providing significant patient experience data with respect to the claim encounters, longitudinal records, as well as the prescription patterns by region, by states, etc., which are available, both commercially as well as publicly available ones. So the vendors have harnessed the data and are using to understand the trends across the nation, regions, or your specific areas, and creating the right value-based care programs aligned to incentivize the providers as well. So the providers also play a major part of the role, because as we see COVID conditions last year, we have learned a lot on that, but the post-pandemic scenario is going to be more complex for the value-based care programs, because the long-term impact of COVID, understanding that is going to be something where we need to start looking into as a technology, and understand how different geographies, age groups, chronic conditions have actually going to be impacted, and how we have to administer them through the value-based care programs.
Thank you so much. And Summer, so I'm going to come to you now, which is to ask you about, again, this sort of nimbleness in this space is, it's hard for payers who are sitting with systems that really are on a fee-for-service chassis. And you work for an organization that has configured some of these algorithms, the Prometheus-based and others that support at the foundation many of these models. So I think it'd be really helpful to understand from your perspective, how do you see using the tools that we have to be able to really continue to grow these models, support the providers and the payers, and really start to see them scale at in a bigger way than we've seen to this point?
Yeah, no, thanks, Lily. And, I think you bring up a couple of good points there. For me, I've always been a data geek or an information junkie at heart. And I get excited when I can sort of learn new things and use that information to be better at what I do. I'll harken back to what Jack said earlier in this session. Growing up in infectious disease, literally growing up in HIV. My mom was an HIV researcher at a big university, and growing up at the time when, the HIV epidemic was raging, and, entering medicine at a time when it was starting to kind of peak and we were finally kind of getting our arms around it. I think some of the lessons learned in that environment for me, clinically, even all the way back to medical school, in HIV, part of the way we were successful, to your point about being able to sort of scale and be nimble, we had good definitions, good evidence-based guidelines, good processes, and we were able to push those processes out. So it was very clear who has HIV, who has AIDS, what are the best medication protocols available, updating those constantly as new medications came out, new literature came out. Same way as it related to care processes. I remember one of the big innovations was the inpatient unit at San Francisco General. And I myself, my very first internal medicine rotation as a freshly minted intern was at the West 900 AIDS unit at Charity Hospital in New Orleans. Very, very sort of structured, focused ways to understand what do we know, but also as we learn new things, how do we incorporate those new things and continue to provide consistent care across the board. And same way, sharing knowledge, sharing information between various research and care institutions across the country, around the world, really. We talked today about platforms and data sharing, but even just, simple symposiums, putting literature out, just sharing information, sharing knowledge, and being able to give everyone a chance to learn and standardize really went a long way. So I think if I come back to, what you mentioned around these value-based care programs, you referenced Prometheus, and I think where that really resonates for me is this idea of having standard definitions, having standard criteria, and having a transparent, collaborative way to continue to incorporate new information, to expand upon that new information, and have everybody involved, payers, providers, whoever, have visibility into really what we're talking about. What are those definitions, those criteria, where they come from, and why? For me, it really resonates with the idea of that concept of transparency. We're all working together. We're all on the same team. Let's be open and transparent with each other so we can all benefit together. And I'll say also, just from personal experience, I've had the opportunity both to lead an ACO and to be the CIO of a Medicaid health plan. And so I've kind of seen things from both sides. And I know, at the health plan, we really were proud of some of the technology we supported, the reports that we put out. We thought we generated some really good insights. And it was a bit of a struggle at times to sort of convince providers, hey, you really should take a look at this and let's talk and let's see how this can make your practice better. I will say on the other end, though, as an ACO, working with a number of health plans around commercial and Medicaid, Medicare ACOs, as well as bundled payment programs, we kind of had the opposite approach. We have our own analytics. Just give us the data. We want to standardize it so all our docs are operating the same way and using our processes. And I think what we found was routinely there was a disconnect in what we thought we were analyzing on the provider side and what the payers were showing us, in terms of the reports that we were seeing. So, I think one of the big takeaways for me there is this idea that, even if we're using the same data, the way we analyze it, the way we use that data, the way we operate against it, we can create problems for ourselves as payers and providers if we don't keep an open dialogue of communication and if we don't sort of measure the same things the same way, to where we're getting consistent information off of our data and then making collaborative and effective decisions together. So I think for me, that's really one of my biggest takeaways just from the personal experience and the evolution of value-based care, is the idea that let's measure the same things the same way together, and then let's talk about together how we're going to improve.
Thank you so much. And I love that discussion about the collaboration, of course, and sort of everybody engaged in the discussion. So it can't even just be the payer and the provider. It really needs to be the folks who are supporting the technology and providing the data. And often, I will recommend to groups that they invite in their tech partners, even just as listeners, to hear what is it that this group is trying to actually achieve. How is it that the docs, what data are they saying they need and how will they use it? And what data does the payer or other group that we're looking at have? And it's so important to do that because the folks who are on the technology side, you'll hear it differently than I on the business side might hear it, or than Dr. Phelps might on the clinical side. So I'm sort of secretly cheering when you say that, Summer. I think it's just so critically important to have as many of the stakeholders engaged in the discussion right from the beginning. So Jack, I'm going to come back to you. And for those who don't know, because we talked about Lifeline, Dr. Phelps is the Chief Medical Executive Officer for Unified Women's Health, which is a multi-state organization that has OBGYN affiliates in a number of states. And I would love it if you could share with us, some of the really interesting, exciting things that you're seeing that are supporting value-based care, and some of the really cool, exciting things that you're doing to support the advancement of value. Because I know among the provider community, I can't think of, I can't really think of anybody I know who's sort of more of a cheerleader and a doer in this space. Jack, I think you're muted.
You are correct. I was just following instructions from before. So thanks, Lily. To start, it reminds me of a quote from Thomas Edison, who said, "Vision without execution is hallucination." And so value-based care and all of the tools we have, the analytics, Prometheus, all of the data, the models, they're wonderful and they're wonderful tools. But unless we can execute at the point of care and get these tools into the hands of our doctors and our providers, and teach our doctors and our providers that you do not need to go back to medical school or get a PhD in data analytics to practice value-based care, then it just is an academic exercise. It's a vision that's an hallucination. So what we're doing at Unified, which is really exciting, is we are taking all of those tools and then bringing those tools right down to the practice level. We're building dashboards, working with our health plans. We have tools called touchpoint algorithms, which our team has built across the country, which are best practices, not only on quality, but on affordability of care. And we're hiring care managers at the point of care to help our providers basically see what opportunities. So what we're doing is using all of the tools that are put out there by health plans, by Change, by all of the organizations, and we're basically trying to get them in the hands of our providers so that they can use them in a way that benefits their patients without having to train to do some other thing that they didn't train for. They train to provide the best care to patients. We don't want them to steer away from that and be distracted from that. So we need to put seamless tools into our doctors and providers' hands so they can give. And it's truly a team effort. As I said before, it's multi-stakeholder effort, and it all ends up with the patient at the point of care, because other than that, it becomes an academic exercise. And we know how bad those things end when doctors don't buy into it, they don't understand it, or they feel that it's really not going to benefit their patients. So that's what we're doing at Unified, taking our team, helping our doctors with a seamless transition in this journey to give better care to their patients.
Thank you so much. And Mignon, I'm thinking if you could share with us sort of from your perspective what payers are focusing on, or what the payer you're with is focusing on in terms of how to continue to advance specialty care, in particular value-based models.
Well, basically, I can speak for us personally. We have hired additional staff to do that. I think I've probably told some of you guys along the way. A lot of times we don't have focused teams on just bundle payments and episode-based payments. We kind of have had to do it off the side of our desk with being responsible for so many other things. And of course, it takes time to continue to grow those programs when you don't have an increased focus. So as a company, we have done that, and now we have a focused group to work specifically with our providers on expansion. In addition to that, like I said, we are just looking at different tools and things that we can put into place that we can grow episodes that are nationally recognized, like the Prometheus episodes that already have the methodology built. Plus, we're looking at custom episodes. We're trying to, again, be nimble where we can work with providers on episodes that that are very important. They're high cost episodes, but we may not necessarily have an out of the box methodology built for. So just working with our analytics and our partners in such a way where we can meet our provider needs. And that's one thing that we're doing, and just providing an increased focus on doing the right thing, trying to get things set up and it initially and working with providers who are engaged and who want to do the right thing for our members. Again, this is one thing that I have seen just across our state is these type of episode-based payments are not, our state is very green to value-based care in specialty care, in my opinion. A lot of our providers just truly have never had any exposure to it whatsoever. And we've had an increased focus over the last couple of years working with our primary care physicians through our Blue Premier program, but specialty value-based care has not been a priority, it's not been a focus, and our providers just haven't seen it from other payers either. So just getting them acclimated to it and just hitting the ground running and just giving them as much information that they can so they are comfortable with it, because again, it's completely something that they're not familiar with. And everybody goes into something with a little bit of uncertainty. And of course, everybody thinks that, well, the only reason you want me in this is to just, reduce costs, just cut costs. It's not about that. I think everybody knows that, the more, you focus on quality, the more you're doing the right thing at the right time for your members, the more it helps everybody. It truly does. And we've got to have a focus on that as we move forward, to reduce costs for everybody, in this space. So just having an increased focus, I think, is important, and having, talking with the right partners and just getting it done.
I think what you said is so right. I think there's so much suspicion on the part of providers, on the part of payers, on the part of stakeholders across the continuum because of the way business has always been conducted in fee for service, right? Where we just focus on units of care and units of cost. And I think it's why this kind of forum is so important to talk about from all these perspectives. What are the challenges and how do you overcome them, and what are the successes, so that we don't continue to reinvent the wheel, but that we actually learn from each other. So thank you for sharing about that. And along the same line, Steve, I wonder if you could talk with us a little bit about what some of the key technology developments that you're seeing, either coming down the path or that have come down the path to solve some of the challenges that both payers and providers are experiencing as they try to launch.
Yes, so especially with the value-based care, the biggest roadblock, or what we can say, data transparency, and as well as program transparency across payers and providers. So we have technologies which have evolved, and we are working with interoperability for so long right now. So there are new methods, new standards which are coming in, which are helping to be able to achieve the goal, both from payer and provider perspective. So one of them, from a optimizing the interoperability, is more of a FHIR standard, which is becoming more predominant and become kind of more of a mandate in the recent past. And it's a very good channel to be able to have a standardized way of data sharing, not only between payers, but also across the providers from a collaboration standpoint, from a continuum of care. You could use FHIR standards more from between both payers and providers to kind of do a simultaneous authorization process, or share your clinical data or the transactions to help in identifying the patients who directly need, right, the costs related to that, and identifying the patients at the right time who needs the maximum care, or accurately track, for example, the episode of cost based on that when the patient is visiting a doctor or a provider at that point of time. So that's one area where it is continuously growing. Then the aspects with respect to the predictive modeling also are growing, which is combined with episode of care to kind of identify who the patients who need the care most, especially in your chronic bundles, or the population whom we are managing through a chronic conditions like cancer, kidney disease, where you want to create specialized programs in managing those complex chronic conditions. That area where it is growing in terms of the tools and the technologies which are available. There are AI-enabled solutions which are actually improving from a technology where you can actually gain insights into your episode analytics, where you can see the patient risk profiles, usage patterns like the 30-day mortality rates, or ER admissions, readmissions within a specific episode, and use that data to kind of drive the decisions at the point of care, as well as when you are actually setting up a new value-based care program associated with that. So again, we talked about that, some of the specialties. I think that's where the criteria-based selections of provider network, like specialty specific providers who are actually demonstrating a very high quality of care and outcomes, could be one area where the analytics is helping and driving to know who are the best performers, and giving that visibility across your provider and payer partners would help in knowing what's the cost, what's the average cost, your benchmarks, and how you are actually performing. The last part to add to that one is we have to adopt the technologies to be able to meet the real patient needs. Means we are seeing a lot of some of these technologies which are directly reaching out to the consumers more and support them at the point where the care is needed or where it is more valuable. Like introducing home hospitalization programs, adopting that as part of your episode of care costs, and modeling that and utilizing that technology to administer the patients from a home health setting or from a home hospitalization setting could be some areas where we would see some improvements in the future. And using telehealth services also would play a critical role through the current situation and the learnings what we are having to see certain services could be administered through a telehealth visit, and you would want to capture that as part of your episodic cost of care model, etc.
Thank you so much. Summer, I'm going to ask you the last question. And you talked earlier about growing up in the midst of the HIV epidemic, and your mom being a healthcare worker. And I think during the late 80s, early 90s, we had extraordinary learnings and innovations around the importance of and how to engage affected individuals in the design of their own care. And we began to see things like peer education, be really successful. And I think, I wonder if you could talk a little bit about, from your perspective, how does the patient, the member, the consumer, whoever the person is from your perspective, in these models, and how do we ensure that they're engaged and we're reflecting not just what we as a payer, as a provider, as a data analyst think are important outcomes, but what the patient individual also believes is important.
Yeah, Lily, I think it's a really important point. And I will say, I joke with people, it depends on the conversation you're in, whether you use the term consumer, member, patient. At the end of the day, we're just talking about people. It's all of us, right? Literally all of us are impacted in some way by all the things we're talking about here. And I think all of us are consumers to some degree. Most of us will be members of a health plan. Many of us will become patients when we engage in the health system. When we talk about value-based care, I think, to be honest with you, most folks don't really know what value-based care is. If I think about some of those late night shows where they walk around on the street, interview people randomly and ask them, questions, I can imagine the answers you get when you say, what is value-based care? And, I think in the end, really, honestly, if we're all successful, and I think Jack kind of alluded to this earlier, if we're all successful in this transformation, value-based care just becomes care. And people just feel like my healthcare system is better. I get more for my money. I feel good about the experience I get. I feel like I'm healthier with better access to services that match what I need when I need it. And really, I think in a very simplistic way, that's what value-based care is all about. It's the right care at the right time, for the right person. And that's going to be different for all of us at different moments in our lives, depending on what's going on. When I think about really the push around consumerism, consumer transparency, all the way down to the point of member and patient engagement, really getting people more actively involved in their health. Mignon touched on the idea of, the specialist programs and the PCP-oriented programs. I think one thing that I'm seeing in a good way is really a blurring of that distinction. We've had very early models of healthcare, patient-centered medical home, ACO, bundle payment program. We're seeing some new iterations coming out both from the private sector and the public sector with some of the new models that CMMI has been helping to formulate. But ultimately, I think what we're really seeing is more of this blending to where we're really encouraging through these payment models, primary care, specialists, inpatient, outpatient, post-acute care, everybody really working together on behalf of the patient. And in many ways, trying to figure out how do we incorporate the patient into that decision-making. So, I talked a little bit earlier about having sort of common industry standards, common industry analytics. So we're all sort of a choir singing from the same hymn book, so to speak. And, I think part of that includes incorporating the patient, the member, the consumer, giving those folks the same ability to understand what am I really talking about. If I'm looking at shoppable services to try to understand where do I want to go for the knee replacement, where's the best place for me. If I'm going to have a baby, where's the best place for me? Who's the doctor I really want to see that matches what I need, what I want, what I need out of my healthcare experience? I think that's where, as we not only start to pull the patient and member into the conversation, but put them in the same conversation, give them the same standards, the same definitions, the same information. It's always going to be adapted a little bit to what they need to know, just like the way a payer sees information will be different than the way a provider sees and consumes information. Patients will want to consume it in a different way, but ultimately, as long as it's the same information that's adapted in a way that they can consume and understand and engage, I think that goes a long way towards the idea that as we talk about price transparency, as we talk about member engagement, as we talk about delivering value and experience, when folks feel like they're part of the conversation, they understand the conversation isn't about them, but it's with them. I think that's when we take that collaboration to the next level and really look forward to where we can take these concepts of value-based care and, like say, just turn it into care, just make that the normal.
That's great. Thank you so much. I know we want to leave some time for the audience participants to ask some questions, and I think Steve's been fielding those for us. So Steve, send them on our way.
Hi, everyone. I'll pop on since we have this spare box sitting here, but we do have our first audience question, and this is directed to Summer. It is good to hear that there are a lot of new predictive analytics driven metrics available for providers, but is it helping providers who already have a ton of things to consider within an average encounter of about 15 minutes long? Are you aware of some tools that are reducing the data overload?
And thanks, Steve. That's a really good question. And actually, Jack, I'll ask you to help me answer this one as well, because you touched on earlier the idea of getting into workflow. And I think that's really the key. So as the questioner mentioned, a lot of tools, it's easy to get information overload. I think the key really is, can you deliver the right information at the right moment in time to make a decision? So, in that sense, whether that's delivered directly through an EMR or through tools that kind of layer into EMRs, apps, that sort of thing, really, I think the key is, can you distill down the right information at the right time for that decision to be made in a way where it's additive and not disruptive? So there's a number of folks that are doing that pretty well. I think the challenge is always scale. Can you do that across multiple providers, multiple EMRs, multiple payer programs, and all that? And Jack, I'll kind of defer to you as well. I know you've been knee deep in a lot of this stuff as well.
Yeah, and it's a great question. And first of all, the interesting factoid is in 1950, healthcare information doubled every 50 years. In 2020, it's doubling every 74 days. There's absolutely no way for physicians or providers to keep up with that without help or without simplification. It's just a fact. And so one of the things I think is important is we need to get away from this fee for volume. We can't do value-based care. I think Mignon addressed it the other day during our prep. You can't do value-based care as a provider or a health plan off the side of your desk. And that's what we're doing now. We're 98% in the fee-for-service world, and we're doing everything that matters for the future off the side of our desks. We have to change that paradigm and get serious about investing in value-based care. Then we need to get the right tools. For example, one of the things we're working on at Unified with our touchpoint algorithms is clinical decision support tool. So that when physicians or other providers see a patient, it's not all 100% by memory. We can't possibly remember getting it right every time. And it's so important. Imagine if a pilot didn't have an onboard computer. Imagine if a pilot forgot to put their landing gear down, and instead of a bell going off saying landing gear not down, they crashed every day. We do that every day when seeing patients. So we need the tools, clinical decision support tools, to help us that don't burden us, EMRs that aren't a black hole of data where you put every bit of data in and you can't get anything meaningful out. We need tools that don't burden our day, but simplify our day so providers can go back to giving care to patients. As you said, Summer, the care is what matters. Everything else should be a tool that isn't a distraction.
Okay, we have another question. Summer spoke to the importance of using evidence-based criteria and common definitions. How are these criteria and definitions developed or sourced?
Yeah. So
It can go to Summer or to anyone who'd like to take it.
I'll share a little bit, and then I'll certainly ask for everyone else to weigh in. So, in terms of how these common criteria and definitions are created, it really comes down to collaboration. So, across healthcare, there's a lot of different perspectives on what's sort of right or wrong, so to speak. But as we work together through peer review across a broad swath of folks, I'll say within Change Healthcare, we have our own internal experts, but we heavily collaborate externally through networks of physicians, professional groups, as well as literature searchers ourselves to really come towards more of a consensus model about what's the right set of definitions and the right set of criteria. But then also having a framework to constantly be scanning updates in literature, getting additional expert opinion to make those updates and changes, because the world is constantly changing. There's new information that comes out literally every day. And, so from that perspective, I think, there's a lot of organizations out there that do a really good job of putting out public literature, public guidelines, and we definitely try to take advantage of that. What we also recognize is that no one person, no one organization knows everything there is to know about everything in healthcare, right? And so that collaboration, that transparency, making sure everything is open, everyone has a chance to kind of vet it, validate, critique, get to a consensus on what seems to be the best available information and the definition that works to support the kind of programs that we all want to see. That's really what we strive for.
If I could just jump in, Steve, before you go to the next question, I would say one of the beauties of these models and the collaboration is the opportunity to really leverage the expertise of the various stakeholders in ways that we have not been able to do in fee-for-service. And so in building clinical algorithms, it's the clinicians, it's the providers, it's not the payer, it's not the business people who have that particular expertise. And so we, in a really collaborative model, you would leverage the expertise that the clinicians in that specialty have to build the models that address the variations in the data that the payer, for example, provides. So just reinforcing really what you're saying, Summer, but I think really important to understand the value that each stakeholder brings to the table.
Well, that takes us to the top of our hour. It went so fast, thanks to our great panel. It's now time to conclude the presentation. Thank you again to our presenters, Lily, Dr. Feldt, Summer, Mignon, and Siva. And thank you to our audience for some great questions. The group at Change Healthcare will be reaching out to answer some of the questions if we didn't get a chance to answer those this afternoon. To our audience, we value your time and feedback. Please take a moment to fill out our brief post-webinar survey so that we can provide the best content and resources for you in the future. We'd like to once again thank the sponsor of today's webinar, Change Healthcare. To learn more, please visit changehealthcare.com. This webinar will be available on demand, and a link to a recording and a copy of the slides, there's only 3 slides, but you will get a copy of those, will be sent to webinar attendees within the next 48 hours. This concludes today's presentation. Have a great rest of your day, and thank you again for your time.
Thank you.
Thank you.